Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I'd like to welcome our audience to today's event. We are joined by Dr. Nicole Lamanna, Associate Professor of Clinical Medicine in the Division of Hematology Oncology at Columbia University Medical School and a member of CLL Society's Medical Advisory Board. Dr. Lamanna will be sharing the latest trial information from ASH 2023 on zanubrutinib, combinations of ibrutinib and venetoclax, and how they can use MRD to guide therapeutic decisions, and finally, Pirtobrutinib. I will be presenting research from ASH in regards to BTK degraders, recent trial data on venetoclax, real-world data, and lastly, clinical information that's combined and looking at treating one of the great unmet needs in CLL, Richter's transformation, that look at one trial looking at Pirtobrutinib and another combining looking at anti-CD19 CAR T therapies and their success with Richter's transformation. So let's get started. So in the way of introduction, ASH, the American Society of Hematology's annual meeting, is the largest congress for hematologists and researchers in blood cancer. And most of the papers that are going to be important are presented at their annual meeting. There were several hundred papers on CLL, but Dr. Lamanna and I, between us, chose about 7 to present. Somewhat of an arbitrary choice, but let's go through those because we thought these would be examples of things that were new or important for our community to understand. The first one I'm going to present is very exciting because it's the first in human phase 1 trial, the first time this kind of drug has been used. And it's NX-2127, a first-in-class Bruton tyrosine kinase dual-targeted protein degrader with immunomodulatory activity in patients with relapsed refractory B-cell malignancies. And Dr. Alexey Danilov was the presenter of this. So we've talked a lot about BTK inhibitors like ibrutinib, acalabrutinib, zanubrutinib, and most recently Pirtobrutinib that have revolutionized the treatment of CLL. But emerging BTK-resistant mutations, as well as what's called the scaffolding function, which I'm going to explain a little bit more of BTK, presents a need for new approaches as these drugs sometimes lose their efficacy. NX-2127 is an oral, first-in-class, dual-function small molecule degrader that combines BT degradation with immunomodulatory activity. And I'll explain what that means. But let's first talk about how it works in comparison to other molecules that inhibit Bruton's tyrosine kinase. So we know that blocking Bruton's tyrosine kinase is critical in CLL because the CLL cells are addicted to the B cell receptor, and the BTK is on that pathway, and blocking it blocks the reception and leads to the cells having no particular purpose, no signaling to stay alive, to reproduce, and they die off. That's the incredible success of ibrutinib, acalabrutinib, zanubrutinib, and Pirtobrutinib. But resistance can develop. The way that first generation of BTK inhibitors work, ibrutinib, acalabrutinib, and zanubrutinib, is they bind in a pocket. That pocket is called C481. And if that pocket mutates, then the BTK inhibitor stops working. Pirtobrutinib, which was recently approved in CLL, and nemtabrutinib, which is in development, don't bind They're reversible binders, unlike the first generation, which are irreversible, or they're non-covalent binders, and they bind differently. So even if there is a mutation in the BTK inhibitor, in the pocket where the BTK inhibitor would bind, they will still continue to work. The BTK degraders that we're talking about now, NX2127, works entirely differently. What it does is it has two parts to it, with a linker in between those two parts. One part attaches to BTK, and the other part, at the other end of the linker, attaches to the cell's garbage disposal mechanism and marks the BTK to be chewed up, to be degraded, to be eaten. So it's not just blocking it. What the degrader does is actually chew it up and destroy it, so there's no BTK left. This is particularly important because the BTK is part of this assemblage that we talked about that goes from the B cell receptor to the nucleus of the cell, saying stay alive, reproduce, and blocking it stops that. But there's still some signaling that gets through just because of the structure of the BTK being part of that. When you chew it all up and there's no BTK left at all, that scaffolding function of it is lost too. So even a weaker signal does not get through. So let's look at the data for this first-in-human phase 1 trial. 47 patients took this drug, once daily doses of 100 milligrams, 200 milligrams, and 300 milligrams. 2/3 were male, median age was 74, so fairly representative of the CLL population. 29 of those 47 were CLL or SLL patients. They were heavily pretreated with a median of 5 prior treatments. 100% of them had had a prior BTK inhibitor. 3 out of 4 had had a BCL2 inhibitor, which would be mostly Venetoclax, and most were resistant to their BTK inhibitors. What were the adverse events we saw? Almost half of them had fatigue. Low neutrophil count was seen in 38%, hypertension in almost 15%, anemia in almost 13%. Something that was a little concerning was confusion, which was seen in almost 18%. That seems to be less of a problem at the lower doses. And like all things that work on BTK, atrial fibrillation was seen. What were the clinical results in those patients? Well, we had 9 partial remissions, 11 stable disease, and 4 patients progressed. The go-forward dose is 300 milligrams. This is a promising therapy in difficult to treat patients, but I have to tell you right now that the partial trial, as we're speaking now, is on a partial hold not due to any safety concerns, but due to a manufacturing issue. And there's another drug in this class, NX5948, is a similar degrader in open trials, but it only has BTK activity that just recently received FDA Fast Track designation for CLL, SLL. The 2127 drug has these immunomodulatory effects. And what that means is it modifies the immune system in a way that some old drugs that were explored to treat CLL, like lenalidomide, and thalidomide, those are not used much in CLL anymore, but they still have activity. These are extremely active drugs, but they are not being pursued in CLL much anymore. And they seem to tweak the immune system and help. But there's also adverse events associated with them, so it's hopeful that the 5948 will have fewer adverse events moving forward. Let's look at another trial, which is clinical outcomes with Venetoclax-based regimens in CLL. And there were several papers that looked at this, and I just chose one. The main title of this was Clinical Outcomes with Venetoclax-based Treatment Regimens in Patients with Chronic Lymphocytic Leukemia. And this was Dr. Hempel from Mayo. The goal was to identify factors that impact the outcome of Venetoclax for patients with CLL treated at a tertiary center, in this case, Mayo Clinic. They looked at different groups, use of Venetoclax frontline, use of Venetoclax with who in patients who had relapsed, who had never had a BTK drug before, and those who relapsed with prior BTK inhibitors. So they were able to gather the data on 155 patients between 2012 and 2023 at Mayo. 55 were frontline, and that was in combination with obinutuzumab or Gazyva, and 100 were relapsed CLL, of which 17 had not had a BTK inhibitor, and the majority, 83, had a BTK inhibitor, with 55 of those progressing after the BTK inhibitor. The median treatment-free survival for the overall cohort was 39 months. So 3 years and 3 months. The median overall survival was 54 months, so 4.5 years. Among patients treated with Venetoclax as first line, that was 55, the 2-year treatment-free survival and the 2-year overall survival were both 91%. MRD testing was performed in 28 patients and was undetectable measurable residual disease in 23. That's 82% of the patients. And there was differences a little bit in where the bone marrow or the blood was assessed. Let's continue to look. Patients treated with Venetoclax in the relapsed BTK naive setting, which is only 17, so these patients had relapsed after other drugs besides BTK. The treatment-free survival was 73%, and the 2-year overall survival was 100%. MRD testing was performed in 7 patients and was undetectable in all 7. Among relapsed BTK-exposed patients, Venetoclax-treated patients, the median treatment-free survival was 26.9 months, and the overall survival was 39.4 months. The median treatment-free survival for patients with and without prior disease progression on a BTK inhibitor was 22 months and 42 months. So you can see that's quite a significant difference. So if patients had relapsed, had progressive disease while on their BTK inhibitor, they could expect less than 2 years out of the Venetoclax. If they hadn't, they could expect 3.5 years. Median treatment-free survival with Venetoclax monotherapy was 24 months, and in combination with rituximab was 26.9 months, and in combination with obinutuzumab was 39 months. So we can clearly see that adding obinutuzumab makes a significant clinical difference for patients. Let's look at a few more things before we get to the conclusion. TP53 disruption, so 17p deletion or a mutated TP53. The poor prognostic unmutated IGVH, older age, complex karyotype, which is defined as 3 or more chromosomal aberrations, and disease progression on prior BTK were all associated with shorter treatment-free survival in the overall cohort. Not surprising. BTK disruption, older age, complex karyotype, and disease progression on prior BTK were associated with shorter overall survival also. So not only did you got quicker to needing treatment, you also lived less time. So in conclusion, patients with BTK-exposed CLL, particularly those with prior disease progression on a BTK, had a worse outcome with Venetoclax. Complex karyotype was a predictor of it was a predictor of a risk of having a poor outcome in terms of treatment-free survival and overall survival. Let's switch to looking at Richter's transformation and CAR-Ts for Richter's. This is a retrospective collective study. Dr. Adam Katai presented this, and the full title was Anti-CD19 Chimeric Antigen Receptor T-Cell Therapy, or CAR-T, for Richter's transformation and international multi-center retrospective studies. So CAR-T, as we know, has dramatically improved the outcome for patients with diffuse large B-cell lymphoma, DLBCL. But Richter's transformation, which is usually diffuse large B-cell lymphoma, has been mostly excluded from these trials. Reminding everyone that Richter's transformation is CLL that transforms into a more aggressive lymphoma. So what were the results? 62 patients were included. This is quite a large cohort of patients because Richter's still, thankfully, is a relatively rare disorder. Median therapy for both prior CLL and for the Richter's itself was 2, difficult group to treat. 84% of patients had received a prior BTK inhibitor or a BCL2, Venetoclax being the main one, the only one that's approved. Ki 67 was 80%. Ki 67 is the measure of how fast the cancer is growing, and that means that the cancer was growing very fast. That's typical of Richter's. The SUV is a measure of the metabolic activity as seen on a PET scan, and 15 is a high measurement. The lymph node side was 3.8 centimeters, so significantly enlarged lymph nodes. The median weight from when the blood was collected through apheresis, which is a special kind of centrifuge to collect the T cells, to actually receiving the CAR T cells, was over a month. And remember that this Richter's transformation is growing quickly during that month. So it's not surprising that 84% of patients had bridging therapy or treatment to control the CLL while they were waiting to get their CAR Ts. What was the result? What was surprisingly good, the overall response rate was 65%, so almost 2 out of 3 patients responded, with 29 or 47% and 11, 18% receiving either getting a complete response or a partial response, respectively. At a follow-up of a little over 2 years, the median progression-free survival was 4.7 months, and the overall survival was 8.5 months. Median duration of response was with the median not reached for patients who achieved a complete remission, but only 2.3 months for those who received a partial admission. Why is this number so much better than the overall numbers? Because this is only looking at the patients who responded to the therapy. Let's take a look at more results. 39 patients died, 28 due to progression of disease, 11 for other reasons, including infections, half of which were COVID, septic shock, stroke, and respiratory failure. 3 of the patients that were in a complete remission went on to a bone marrow transplant. 2 were still alive at last known follow-up, and 1 died post-transplant of progressive disease. 55 or 89% of the patients had cytokine release syndrome, and 15%, this was quite severe, more than grade 3 or more. 69% had some neurotoxicities, these are called ICANS, and 23 or 38% had significant ICANS, grade 3 or higher. So in conclusion, this is the largest cohort that's ever been studied for Richter's who received CAR T therapy directed at CD19, which is a surface marker on CLL cells, and that's why it's so effective. The thought is that maybe using these earlier when the patients are less beaten up and their T cells are more effective might result in better outcomes. Follow-up with transplant seems to improve outcomes. CAR T combinations with novel agents are also in trials now, and that's probably the future. But even with this, Richter's remains a major unmet need, though these results are better than the historical results that we've normally seen with chemoimmunotherapy. Let's look at another possible treatment for Richter's transformation, and that's Pirtobrutinib, which we're hearing about from Dr. Lamanna in terms of treating CLL. This is Dr. Bill Weirda out of MD Anderson, presented, and the formal title is Pirtobrutinib and Richter's Transformation, Updated Efficacy and Safety Results with an 18-month median survival follow-up from the phase 1/2 Bruin study. Richter's transformation, as we've learned about earlier, is something that none of us want. It occurs in about 1 out of 10 CLL patients. There is no standard of care, so often a clinical trial is the best option. This updates data from the Bruin trial on the use of Pirtobrutinib in Richter's transformation. What were the results? So among all the patients with Richter's, and this was 82, The median age was 67, and the median lines of prior therapy was 4. The overall response rates was 1 out of 2, 50%, including complete remissions in 13.4 and partial in 36.6. For 61 patients who received prior covalent BTK inhibitor, such as ibrutinib, acalabrutinib, or zanubrutinib, the overall response rate was 45.9%, so a little bit lower. At median follow-up of 9.7 months, the median duration of response for all 82 Richter's transformation patients was 7.4%. 8 patients stopped pirtobrutinib to go for a bone marrow transplant because this is a transplant from someone else, and this has the intent to cure, as we learned, and it can be successful, as we learned from the other trial data. This is not a risk-free therapy. There were low neutrophil counts in 3 out of 10 patients, fatigue in a quarter of patients, and 18% had diarrhea, shortness of breath, low platelet counts, or fever. Interesting, only 3 had hypertension, and there was only 1 case of atrial fibrillation. But the bottom line is that no one stopped pirtobrutinib due to a side effect. So in conclusion, pirtobrutinib is a well-tolerated and has some activity in Richter's transformation that needs to be explored. Better treatments for Richters are needed. Thank you for listening to these 4 quick presentations, and now it's my great pleasure to introduce Dr. Nicole Lamanna as the next speaker.
Hi, I'm Nicole Lamanna from Columbia University Medical Center in New York. I'm going to present some of the highlights from the American Society of Hematology meeting that was held in December 2023 in San Diego. We're going to focus on 3 abstracts that I'm going to present. One is a follow-up to the Alpine study. This is a study looking at zanubrutinib versus ibrutinib in relapsed refractory CLL/SLL patients. And another abstract, Pirtobrutinib from the Bruin study. This is a follow-up. This is a non-covalent BTK inhibitor with longer follow-up from this study. And just full disclaimer, I am authors on both of these studies, so I just want you to know that. And then the third study comes out, it's called the FLAIR study from our international UK group, looking at ibrutinib and Venetoclax versus fludarabine, cyclophosphamide, or rituximab, or FCR, in previously untreated patients with CLL. I'm going to give a little background for those of you who may or may not know. We currently have 3 covalent BTK inhibitors currently approved for CLL, ibrutinib, acalabrutinib, and zanubrutinib. The only BCL2 inhibitor currently approved for CLL is Venetoclax, although there are others in development. And this is usually combined with a monoclonal antibody, either obinutuzumab in the frontline setting or rituximab in the relapse setting, and those are approved combinations that are time-limited therapies. And then we have the first non-covalent BTK inhibitor, Pirtobrutinib, which again, we're going to talk about with the Bruin study, that was approved in December for patients who had received prior covalent BTK inhibitor and a BCL2 inhibitor like Venetoclax. Because some of the abstracts focus on head-to-head data, I want to remind everybody about the adverse events or toxicities that we see with this class of Bruton tyrosine kinase inhibitors. These include cardiac issues, most commonly in irregular heartbeat, such as atrial fibrillation. You can see increased bleeding or bruising with BTK inhibitors. High blood pressure or hypertension is a known side effect of the BTK inhibitors. Some GI issues such as diarrhea. Infection does occur with treatments in general for CLL patients. So I kind of like to say that we see this even with other therapies, increased infection, and in patients even off therapy. We know that patients with CLL have an increased risk of an infection. But certainly we see this on therapy. So we include that with all treatments. And increased arthralgias or myalgias can be seen as well with BTK inhibitors. Now, why this is a class effect, those adverse events I just showed you are a class effect. So we see this across the board with all the BTK inhibitors. But the reason why in some of these head-to-head studies, and we're going to talk about this, is that there might be slight differences in the frequency of the adverse events, is because, you know, we would love these drugs to be as selective as possible. This is, again, it's supposed to target Bruton tyrosine kinase, a particular enzyme, but there's some off-target effects as well. And so sometimes they hit other enzymes, and this explains some of the other toxicities that we see with these agents. And so there might be differences in the off-target effects depending upon the BTK inhibitor. And that's where you might see differences reported in these clinical trials. So I just want you to keep that all in mind. And so less selective BTK inhibitors may have more of these side effects compared to the less selective BTK inhibitors. So let's get to the first abstract. This is the Alpine study. This is in patients who have received prior treatment for their CLL and now need another line of therapy. And so this is a randomized study of zanubrutinib versus ibrutinib. So patients have had to have some prior form of therapy. It couldn't be that they had a prior covalent BTK inhibitor because that's what the study is about. So you can't have prior BTK inhibitor treatment. You had to have measurable disease, meaning you need therapy now. You can't just, be put on the trial. And you were excluded if you were on treatment with Coumadin or warfarin or other vitamin K antagonists. You were then randomized to receive either zanubrutinib at 160 milligrams twice a day or ibrutinib 420 milligrams once a day. And that's the standard doses of both of these agents. This is a longer follow-up of this study that was reported at ASH. So I want you to know this has been previously reported before, but like many trials, we're trying to follow them with longer durations of follow-up so we can see if the changes change over time and what happens with the patients on study over longer periods of time. And so we have over 600 patients randomized on this study. In the zanubrutinib arm, there was 327 patients, 3 were not treated. 130 patients at this median follow-up now at 40 months, so over 3 years of therapy. 130 patients had discontinued zanubrutinib at this point in time. 69 of those were due to some side effect or adverse event. 51 were due to progressive disease. Some withdrew by their own accord. They didn't want to stay on study, and some were lost to follow-up. In the ibrutinib arm, there were 325 patients. 1 was not treated. There were 172 that already discontinued at this point in time, about 39 months of follow-up. 88 were taken off due to some side effect, 62 due to progressive disease. Some withdrew by their own accord. Some were withdrawn by their physician. Others were lost to follow-up. Just to give you a sense of where patients are now with longer follow-up. What we noted in this study is that zanubrutinib continued to demonstrate an increased progression-free survival over ibrutinib. So what is progression-free survival? You're going to hear this term in a lot of clinical trials. And this refers to the time that patients are randomized or when they start their therapy to the occurrence of either progressive disease. So now their disease is starting to grow again, or maybe they died, whether it be due to the study, meaning the drug itself, or due to some other event. But that's, that's the definition of progression-free survival. So we note that as a tick mark. So here again, zanubrutinib continued to demonstrate a better PFS versus ibrutinib in this study at now 39 months. Again, this was previously reported at the 2-year follow-up and also had a split in the curves. And that split in the curve has been maintained with longer follow-up. This was also notable in patients with what they call high-risk disease, either deletion 17p or TP53 mutation. As many of you know, those abnormalities are associated with a higher risk, worse prognosis in general, although thankfully with these BTK inhibitors, patients are doing so much better. But in this head-to-head study, there was an improvement in the progression-free survival with zanubrutinib versus ibrutinib in this study. Albeit smaller patients, you could see 31 on the zanubrutinib arm, 46 on the ibrutinib arm, but the PFS was 59% versus 41% between the 2 arms. And again, that split in the curve has been maintained with longer follow-up. Now, what about these adverse events or side effects that I talked to you about that we see with BTK inhibitors? Now, this study, remember, this is now 3.5 years longer follow-up. This study was conducted during that time period of COVID when things back in 2020, when things were pretty severe with COVID, so that there were patients on both arms who contracted COVID, and some of those patients actually died due to COVID infection on both arms, so that's notable here. And then you have other side effects, neutropenia, which are associated with the BTK inhibitors. You can see that most were grade 1, 2, and 3, but there were some that were grade 4. Increased high blood pressure, so that's pretty similar between zanubrutinib and ibrutinib. Upper respiratory tract infections, diarrhea, arthralgias, and anemia. cardiac events were different between the two drugs. And this is what is notable when we look at the side effects between zanubrutinib and ibrutinib in this study. Serious cardiac adverse events were 3.4% with zanubrutinib versus about 9.6% with ibrutinib. There were lower rates of atrial fibrillation or atrial flutter. That's one of those cardiac events that we talk about with BTK inhibitors. There was lower rates of other ventricular fibrillation and other arrhythmias as well, and no fatal cardiac events with zanubrutinib versus ibrutinib in this study. So that again, less cardiac events with this with zanubrutinib versus ibrutinib in this study. So what are some of the take homes from this study? Zanubrutinib had increased sustained progression-free survival over ibrutinib in this study at now over 39 months of follow-up. There was also an advantage seen in the patients with 17p deletion or TP53. And although there were similar rates of high blood pressure with zanubrutinib and ibrutinib in this study, there were lower rates of cardiac adverse events, fewer rates of leading to discontinuation or dose reduction in this study as well. And then similar to another study, so many of you know that there was another head-to-head study called the Elevate-RR, which was the study of acalabrutinib versus ibrutinib in relapsed refractory CLL patients. There was also less cardiac events, serious cardiac events with acalabrutinib versus ibrutinib in that study. So when I look at these two newer covalent BTK inhibitors, i.e. acalabrutinib and zanubrutinib, we like to say that if a person is going to be on a covalent BTK inhibitor for the first time, they're likely going to be put on one of these newer agents because there's less cardiac issues than ibrutinib in terms of the side effects from these head-to-head studies. So I think that's important. If you're on ibrutinib and doing well, we're going to keep you on ibrutinib because you're likely going to continue to do well. So just to take note of that. Let's move on to the next abstract. So let's talk about non-covalent BTK inhibitors. As I noted, we have the first one that's now FDA approved. This is Pirtobrutinib. So how are these different? They're all BTK inhibitors. They inhibit Bruton tyrosine kinase, but covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib, do this by binding to C481 binding site here in a covalently bound fashion. And the non-covalent BTK inhibitors get around this because they don't require the C481 binding domain to do their job. And so when we talk about patients who are starting to develop resistance to the covalent BTK inhibitors, remember, none of these therapies are curative for CLL. They're excellent therapy. They give durable responses for many patients for years, but we do see that patients eventually may start breaking through their drug. And so, there is a common mutation called a C481S mutation that can develop in patients on covalent BTK inhibitors. And now we have non-covalent BTK inhibitors that are being evaluated that can overcome some of this resistant mutation that we're seeing. And so now fast forward to this study that was represented with longer follow-up at the ASH meeting. This is called the Bruin study. And this was the initial study that looked at Pirtobrutinib in a phase 1/2 fashion. In other words, we first had to figure out what the proper dosing was of the drug. And then, of course, we look at how well it's doing in patients with CLL and SLL. It was also explored in patients with other lymphomatous subtypes as well. For the purpose of this presentation, I'm going to focus on the patients who, the 282 patients who had CLL or SLL who received prior covalent BTK inhibitors and then went on this treatment. So there are 282 of those patients who received either ibrutinib, acalabrutinib, or zanubrutinib, and then they went on to this study. They had to have either been intolerant of their covalent BTK inhibitor, or they had progressed on prior treatment with their covalent BTK inhibitor to be on this study. And when you break that 282 patients down, all of them had to have prior covalent BTK inhibitor, but some of them also had prior Venetoclax treatment or a prior BCL2 inhibitor, whether Venetoclax or maybe they were on a study with another BCL2 inhibitor, and those are called BCL2E or exposed. So 154 of those patients had never had Venetoclax or BCL2 based therapy. 128 of those patients, that was 40% of the total, also had prior BCL2 inhibitor based therapy. When you look at those two patient cohorts, regardless of their prior BCL2 status, whether they were naive or exposed, overall response was very good for both groups. So in the BCL2 naive, so the patients who had never had prior Venetoclax or another BCL2 inhibitor, the response was 83%. For the patients who were BCL2 exposed and had Venetoclax, or some of them were on another clinical trial with a BCL2, 80% of them also had an overall response to this therapy. So that's good news that both, regardless of prior BCL2 exposure, you can respond to this therapy as well. When we look at the progression-free survival of these patients, it is no doubt that the patients who were naive of a BCL2 inhibitor, meaning they had not yet had Venetoclax or a BCL2 inhibitor, were less heavily pretreated. So their progression-free survival was longer at 23 months. So about 2 years, they gained a benefit from treatment with Pirtobrutinib. If you were previously BCL2 exposed, so you had covalent BTK plus Venetoclax, the progression-free survival, it was a little shorter at 16 months. And that makes sense, right? So they're more heavily pretreated. So it did not last as long as if you were naive to Venetoclax. So the conclusion of this abstract, it's a very active agent for patients who have received prior covalent BTK inhibitors, i.e. either Brutinib, Acalabrutinib, or Zanubrutinib. And it also works in those individuals who had prior covalent treatment, but also had prior exposure to Venetoclax or another BCL2 inhibitor. And so that means that patients who need an alternative treatment down the line have now yet another drug that can be successful for the treatment of their CLL. It is now approved for this indication. And when we talk about those adverse events that are atypical of BTK inhibitors, it is very well tolerated as well, and has very low rates of cardiac events such as atrial fibrillation. So very well tolerated so far with about 30 months of follow-up. It still has the adverse events of special interest with BTK inhibitors, but low frequency of those adverse events. And we'll obviously follow that over time. And now you have, now you're gonna see lots of combination of studies with Pirtobrutinib plus Venetoclax and even CD20 monoclonal antibodies and in earlier lines of therapy. So there's lots of clinical trials going on with Pirtobrutinib currently. Now let's get to our last trial. This is called the FLAIR study. This is fludarabine, cyclophosphamide, and rituximab versus an oral combination with ibrutinib and Venetoclax. And this is in the frontline setting. So patients never had treatment for their CLL and now require therapy. So over 500 patients were randomized onto this study. And this is, the fludarabine, cyclophosphamide, and rituximab is given standard of care, and it's 6 months, 6 cycles of therapy, so about 6 months of duration. And the ibrutinib Venetoclax is a little different here. So this is given, we like, as you know, we're trying to look at more time-limited approaches to some of these therapies. Venetoclax obinutuzumab, which is approved as a frontline therapy for patients with untreated CLLs, 12 months in duration. This study looked at an oral combination, but uses MRD or minimal residual disease to sort of figure out how long should somebody stay on ibrutinib and Venetoclax. So if you become an MRD negative, we're going to try to get you off therapy sooner. If you're MRD positive, we're going to keep you on longer. And I'm going to talk a little bit more in detail about that in a moment, because this study did this differently than some other time-limited clinical trials. So again, to be on this study, you had to have no prior therapy. If you had to be fit or less than 75 years old, only because if you're getting randomized to FCR, that's a much more aggressive chemoimmunotherapy regimen. And so they wanted to make sure you were fit for the study. You couldn't have a significant amount of TP53 or deletion 17p because we know that FCR doesn't work well for that subgroup. So then you were not allowed to be on the study. And you couldn't have symptomatic cardiac issues because of the concerns with the ibrutinib or a history of prior Richter's transformation, because that means you had prior therapy before. So let's talk about this MRD guided approach in this study with ibrutinib and Venetoclax. So patients were having serial testing of their peripheral blood to look at minimal residual disease via flow cytometry. So they're looking microscopically for any residual CLL cells via flow cytometry. And if you were deemed, if it was negative, they were going to repeat it again to ensure that it truly was negative. And eventually also they were going to repeat it in your bone marrow to look and see that you were negative in the blood and in the bone marrow. And so they would call that your MRD negative time point. They then continued the ibrutinib and Venetoclax. They doubled that time point that you became MRD negative from when you started treatment to your MRD negative, and doubled the time that then you were going to stay on your combination. So patients can be on ibrutinib and Venetoclax anywhere from 2 years to 6 years, depending upon your minimal residual disease status. So this is a little bit longer therapy as a time-limited therapy than some of the trials that we're seeing who stopped everybody at a certain time point, regardless if you were MRD or not. So keep that in mind. So based on this study, what they showed is that the primary progression-free survival, or PFS, was better in the ibrutinib Venetoclax oral combination versus FCR at 3 years, 97% versus 77%. and at 4 years, 93.5% versus 65%. So again, better than chemoimmunotherapy, which we've seen from a lot of head-to-head trials with targeted therapies versus chemoimmunotherapy strategies, either with FCR or bendamustine rituximab, which is why we've moved away from chemoimmunotherapy. And then the overall survival also trended, not statistically significant yet, but trended favoring ibrutinib and venetoclax over FCR. And hopefully with longer follow-up, we'll see if the curves continue to split. Now, remember, now we're going to talk about that MRD. So just so you know, the complete responses at any given time with FCR was 71.5% versus 92% with I plus V. So I plus V, the complete responses were better. And then when we talk about minimal residual disease, the bone marrow at any time, the FCR 40% versus 62% with I plus V. So also deeper levels of remission with the oral combination versus FCR. Now, to look at when patients actually stop therapy to give an idea, the stopping treatment, and that's this curve below where it says time to attain MRD stopping rules. So when patients stopped because they were determined to be MRD negative, so at about 2 years, about 50% of patients were able to come off therapy because they were MRD negative. At 39 months, 63%, and at 51 months, 73% were off therapy. When you broke those individuals out by their mutational status, if they were unmutated, remember that group is a little less favorable than the mutated folks. It took a longer time for patients who were unmutated to achieve those landmarks and to come off therapy. So they were on I plus V longer than the patients who were mutated. And that, obviously they're a more favorable group. So that gives you a sense. So patients were on this study longer with I plus V for MRD guidance than maybe some of the other studies that you've seen that have been presented, because this is doing it literally by MRD guided patient specifics, and they doubled that time period. There were 5 patients who, prior to the 6-year follow-up, who had come off of I plus V, who had MRD detectable disease again and got restarted and on ibrutinib and venetoclax and are doing well. So let's conclude this last abstract. MRD guided ibrutinib and venetoclax was superior to FCR with respect to progression-free survival at 97 versus 77% at 3 years. The overall survival also favored ibrutinib and venetoclax over FCR at 3 years. And these results actually may be superior than some of the other clinical trials we're looking at with either ibrutinib monotherapy or venetoclax, whether it's monotherapy or in combination with anti-CD20. But remember, that's because they're MRD guided and patients were staying on perhaps this combination longer than in some of the other time-limited clinical trials we've seen up to this time point. So this raises questions about what is time limited. Should it be a blanket time period for all, stop people at a certain time period regardless, and how well do they do? Or should we be utilizing MRD and try to do it more personalized and look at patient care and their outcomes a little bit in this type of a fashion? So we have a lot more work to be done in these clinical trials with regards to MRD, but this is a very interesting study, and we'll be looking to more follow-up long-term of these patients who are on this study, given that they could be potentially on therapy longer. So stay tuned for more work with this study, the FLAIR study, as well as other MRD guided approaches in time-limited combinations for CLL patients. And with that, I want to thank you all, and we'll take any questions shortly.
Well, I sure learned a lot from that, Dr. Lamanna. That was great. That was a ton of information. I hope everyone learned something new from the ASH research. And this was just the tip of the iceberg. There was like 300 plus papers at ASH on CLL. So we obviously left a lot of good research behind. Thank you, Nicole, for this great presentation. Before we start to answer the questions, I just wanted to make one correction to my presentation, and that is that the go-ahead dose on the NX-2127 for CLL is 100 milligrams, not the 300 milligrams, which is the go-ahead dose for other lymphomas. And the research is continuing on NX-5948 right now, but the trials on NX-2127 are on a partial hold now due to some manufacturing but not safety issues, as I mentioned. So we're going to start answering questions. We're going to try to get to as many as we possibly can. But if we're not able to get to your question for time reasons, please email our Ask the Expert email address after this event I will share that on the closing slide. So let's get started. And Dr. Lamanna, I think one of the things that we need to touch on is this whole idea of limited or fixed duration and how we decide on that. And it seems like MRD, there's two ways to do that. We do it right now. You can take Venetoclax for a year. You can take it for 2 years if you're relapsed and refractory. Or, and this isn't standard of practice yet, you can look at MRD and guide it, like Dr. Hillman's paper suggested. Do you see this as the future? Is this where you think things are going? Is this but it's not happening now? Or what's your sense of this direction? Because there's a ton of questions around this particular topic.
I mean, obviously, this is a very difficult topic because one is there are many ways to look at MRD. And so that is constantly evolving with technology. And so some of the studies that we report on might be doing it in one fashion with flow cytometry, others might be doing it with NGS. And so there's technique issues that will change and are modified, and that can also change MRD testing or the meaning of certain clinical trials. In other words, that, you know, as we get more sophisticated, our levels of detection of these microscopic cells might be getting more sophisticated. And on one test, you might really still have had MRD. On another, you know, you might, by a sophisticated testing, you might really still be positive. So that's evolving. And then the second is, how do you, in real time, depending upon where you are, get testing done that can make clinical outcomes and allow for your physician to translate what that means for you. And so that's where MRD testing has not yet been sort of mainstreamed. You see it, and we talk about it on all these clinical trials and reports at these meetings, but it hasn't really made it out yet to the public. One is because we also have to figure out for a particular regimen, what might be a benefit for somebody staying on longer of therapy, and for another person it may not. So patients who given some of the results that you've seen, let's say with Venetoclax and obinutuzumab, which is a time limited therapy that's FDA approved, right now the way that trial ran is that it was 12 months of therapy and everybody discontinued, regardless of MRD status. And so the patients have done really, really well with long-term follow-up, and even patients who might still have MRD might still be able to be off drug for a prolonged period of time. And so we haven't, I think it's incumbent upon us in the clinical trial arena for CLL experts to kind of help translate MRD better for physicians in the community to say, this makes sense, we need to follow MRD because maybe for this group of individuals, it might behoove them to stay on therapy longer, but for this individual, they're going to do well regardless. And so they can actually buy some time off drug and they don't need to continue and extend that therapy. There's also been some studies that have shown that we've, in some trials where when they extended the therapy, some people just plateaued and never improved their response. And another half of those individuals did improve their response and and it was good that they stayed on therapy longer. So we're still trying to figure this out for everybody. And so that's why, do I think we're going to be going towards that direction? I do. Do I think that there's a lot more work to be done in this area? I do. Brian, does that help us best explain it?
I think it does. And let's just touch on the other point with MRD. And maybe, I don't know, maybe you have the answer to this on the FLAIR trial. We can do MRD all these different ways. And we can do 1 in 10,000, 1 in 100,000, maybe down to 1 in a million with next generation sequencing or clonoSEQ. Do you know what Dr. Hillman and his team used?
It was flow and it was 10 to the minus 6. Yeah.
All right.
Yeah. And so not as deep necessarily as some of the other testing. But you have to also understand this type of a trial, actually in many of us view what they did was pretty heroic. This isn't really done, to do all this sampling so frequently and to, as an international trial is a big deal. So we need to do more of these kind of studies. And as I said, some of the studies that we've run up until this time point are pretty arbitrary. When we talk about some of these time limited combinations, we picked arbitrary time points. We didn't know going into it how patients would do in terms of MRD. And obviously now we can look at this and fine tune what time limited might be. And maybe for certain populations, if you have high risk disease, maybe it would be, we'll get better sense of, whether or not you should be on therapy longer or not, because you're not going to do any better. So I think that there's a lot of work that needs to be done with regards to MRD in our time limited therapies.
Yeah, and it always seems arbitrary. How long it takes the Earth to rotate around the sun shouldn't have to do with how long it takes to drive the biology of your disease down. But it is very interesting. And I think Dr. Hillman's hypothesis, because there's still hypothesis at this point, that the velocity, how quickly it falls, determines how it's going to continue, even below where we can see it, it's going to continue to fall. And whether that applies to other therapeutic combinations is very interesting. I think it's a very interesting area. There's another area that I like about the limited duration, whether it's fixed duration or MRD driven. And I think that there's increasing evidence that that may lower the risk of developing resistance to whatever therapy you're on, because it seems, at least with Venetoclax in some studies, that these mutations that confer resistance to Venetoclax tend to develop after you've been on the drug for a couple of years and not immediately. So you may be able to stop the drug and then be able to reuse it again because resistance doesn't tend to develop quickly, at least in that case. So I think that's another big advantage of that. Let me ask you kind of a sophisticated question here. And someone took the trouble to put this question in, and maybe you can explain what this is. A BRCA3 mutation, is that something patients should worry about, and what does that mean?
So there are, this is a complicated question. There are some molecular mutations that can be tested for as well. So many of you are probably aware about the FISH test, right? And so that looks at chromosomal abnormalities that are associated with your CLL cells. Well, there are some other testing that can be done looking at molecular mutations that are also a part of your CLL cells. There's many, and BRCA3 happens to be an uncommon mutation in CLL patients. It's not very common, but the incidence is about 3%. There's other mutations, so for those who are more savvy, the Notch1 mutation. So there are other mutations outside of the FISH testing that can be done. This isn't part of standard of care testing that's normally done on CLL patients, but can be done. And so how do these other mutations, such as Notch1 or BRCA3 or SF3B1, there are others, how do they influence treatments currently? They don't yet. These aren't standard testing, and we don't know yet how to, whether or not certain treatments might change the way those individuals are doing, particularly since targeted therapies are doing very well, even for patients with TP53 mutations, for example. So patients are doing so much better with BTK inhibitors and Venetoclax that they're doing very good. But we don't know with these other mutations, such as a BRCA3, which is very uncommon, how that may yet play into treatment options, or we don't have enough clinical data that might say one therapy is better than another for a patient with this type of mutation. There's a lot of laboratory data and in vitro data, typically BRCA3s were much more chemoimmunotherapy resistant, didn't do as well with fludarabine based treatments. There's some data looking in the lab that because of the way, and again, this is a little bit more sophisticated, but when we look at CLL and the development and evolution of CLL, one of the transcription factors that are important for CLL is NF-kappa B. And so there are two pathways that affect this, and one is a canonical pathway, one's a non-canonical pathway. Again, a lot of science language here, but essentially BRCA3 tends to activate the non-canonical pathway, and the canonical pathway is impacted by BTK. So there's this question about whether BTK inhibitors may not be as good for patients with a BRCA3 mutation because that impacts the non-canonical pathway. The truth is we don't have enough clinical data to know the difference. So there's not enough data to know that one might be, the Venetoclax might be better in that sense versus a BTK inhibitor based on this data, which was in vitro. We need to get that data. And so I think that in some of the clinical trials, when we test for these types of mutations, eventually we might be able to help guide individuals more one way or another. And I think it also impacts on the person with BRCA3 might have a TP53 mutation as well. And so that, then you have to think about other factors, not just the BRCA3 mutation when you're deciding on a particular therapy for a person, but it's an uncommon mutation.
So I'll put an explanation point past that last thing that you said. And when you are looking at next generation sequencing, the one exception that you should look for is 17p deletion, because that will occur in people who aren't 17p deleted, which we've all known about for decades now, may have a 17p deletion. And that's a test that most community hematologists can now do and look for and should be done, because that can significantly change how you're going to approach therapy. An issue that came up in all different ways and was second cancers. There was somebody with a lung cancer, somebody with prostate cancer, somebody with a sarcoma, somebody with Waldenstrom's, multiple myeloma. First, this is much more common, right? Second cancers are much more common in CLL. And as a clinician, now these are outside of the trial, but this is the real world you live in. And a lot of these patients are in their 60s, 70s, 80s, may have a couple cancers. How do you approach that when patients have a couple cancers? How do you work with your oncology colleagues on these cases?
Yeah, absolutely correct, Brian. I mean, so in general, I like to think of, say CLL is a disorder of your immune system in general. And so is it that, chicken or the egg? Is it something that inherently is wrong with your immune system that predispose you to CLL and other cancers, or somehow due to the underlying CLL, your body's not able to do proper immune surveillance and help you fight off these other cancers or other conditions that may be immune generated? And so that there's no doubt there's an increased risk. And so, we always talk to you guys about trying to make sure you're getting properly screened for, dermatology. Skin cancer is the most common other cancer we see actually in CLL patients. And then advocating for doing routine age-appropriate cancer screening, your colonoscopy, your mammography. So screening for those cancers appropriately, because those other cancers are curative. In patients who have CLL and other cancers that Brian was mentioning, lung or multitude of other cancers, it's important that, obviously you're going to be working in tandem with probably your CLL doc and your oncologist for the other cancers. And you'll probably be getting more imaging also due to the fact that they're going to be following up on your other solid tumor cancer if it's a solid tumor. And so you'll be getting surveilled in probably more than one way by both physicians. But it is common to have, unfortunately, CLL patients who have more than one kind of cancer. True.
And I would say often, if that second cancer is more aggressive, which often it is, and because CLL tends to be a slower growing indolent cancer, the precedent is to take care of that other cancer first.
Absolutely.
Now, there are exceptions, like some prostate cancer could be just active surveillance forever, and you don't really have to do anything about that. And that's quite common. A lot of men have both prostate cancer and CLL and can live decades with both. But often the CLL will take a back seat, and that's okay that it can.
Yeah, I think the only thing I'll bring up about that too is that if the CLL is indolent and being monitored and is a backseat, that's great. If you have active CLL going on, or your blood counts are not so good, those two doctors really need to work together on your care, because oftentimes, depending upon the types of therapy for the other cancer, they may have impact on your CLL, your blood counts, or immunologically, because obviously for some of the solid tumors, there's PD-1 inhibitors. There's a lot of targeted therapies, and they can have side effects for CLL patients that might be more prominent. And so those two docs should be definitely, keeping track and monitoring your blood counts, and you maybe perhaps a little bit more differently. If you're getting chemotherapy for another cancer, that will have an impact on your CLL and actually likely treat your CLL as well. And sometimes people need dose modifications and things like that because of the fact that you inherently have a bone marrow disorder and may have impact on your blood counts already, and then you give chemotherapy. So the doctor should talk if you've got another cancer.
Let's talk about the big cancer scare that a lot of patients have. And I'm probably at fault for highlighting a couple of papers here, and that's Richter's transformation or Richter's syndrome. So first, give us a sense, because I've seen different numbers, of how common that is, and are there symptoms that you look for that says, uh-oh, I better check this patient for Richter's?
Yeah, absolutely. I think you said it right before in your talk, Brian. So it's about 1 in 10, about 10%, depending on the literature, right? Anywhere from 5 to 10% or so. It is more common in patients who have had prior therapy. There's no doubt about that. If you've never had therapy for your CLL, it may not be related. So let's talk about clonal relatedness. So there's some individuals who unfortunately just have, can get a transformation, the most common being to a diffuse large cell lymphoma, although there are others. And so if you've never been treated for your CLL and that occurs, it may not be related to your CLL. The pathologist can actually look at this and see if it's related to your CLL. And they
And that's very important, isn't it? Because
it is important. Absolutely. It is important. And clearly, because you haven't been exposed to therapy for your CLL, you're likely to be more sensitive to the treatment for the large cell lymphoma. The majority of patients, unfortunately, are patients that have had treatment for their CLL and then become more resistant and are clonally related to their underlying CLL. And that's when Brian had mentioned about clinical trials and novel therapies and things to do, because this is one area that we feel, clinically we need to do better on, because the therapies haven't been great up until, we traditionally would give chemoimmunotherapy, which is what is given to a lot of large cell lymphoma patients, but doesn't work as well in our patients with CLL who have been resistant, who it's clonally related and have resistant disease due to the fact that they've had prior therapy for their CLL. So we're always looking for better therapies for patients with this, but it's not when you asked about symptoms, usually this is a little different than your CLL. So, usually patients can, they can develop a lot of profound night sweats, fevers, weight loss. Maybe they have a lymph node that seems out of proportion to their other lymph nodes that's, sore, tender, that has come out of the blue. They don't generally feel well. And so something, those types of symptoms then lead your way to the doctors. You bring it up to your physician, and that's when they're oftentimes getting, besides a CAT scan, they'll get a PET scan. And the reason to do that is because the CAT scan, looks at your lymph nodes and the sizes and your organs, but a PET scan will tell us whether or not a particular lymph node is very avid, or what they call hot. So the radiologist will read this in degrees of intensity, and CLL lymph nodes are mature, slow-growing lymphocytes that have a different type of an uptake on a PET scan, whereas something that is large cells are usually much more metabolically active and will have a different uptake on a PET scan. And that's where then we'll say, hey, that's a lymph node I want to biopsy, because it'll help us figure out, is that different from your CLL? We just don't want to biopsy a random lymph node. We know you have CLL, so we're looking for a PET scan. So usually most people present ill, and that there's something going on with them, or they're just feeling profoundly fatigued, or have a lot of night sweats, or a lot of weight loss, or something else that's driving them to feel unwell, and then they undergo an evaluation.
Now, I know that Richters can present at any time. It can actually be how the CLL is discovered. It can come very early, as you pointed out. But is there a typical time that you see it, or is it just completely unpredictable? You could be 2 years out, 5 years out, 15 years out. Is there
Generally, I mean, you're right. There are some cases that occur very early, and then on average, a lot of the Richters are multiply relapse patients on multiple therapies. So maybe more traditionally, a little bit later on down the road, particularly if you've had exposure to multiple treatments. But there are some cases that can occur early. There's no doubt we've seen that.
Let me ask you a philosophical question on Richters here, and that is, my sense is that if you have less disease, you have less CLL to mutate and turn into Richters. So getting into these UMRD states might lower your risk of Richters rather than having a significant tumor burden. Is that just wishful thinking on my part? Is there any logic behind that?
No, I agree. I mean, I would hopefully that we would like to think that would be the case. I don't know if that's the case in all comers, and part of that might also have to do with the genetic makeup of that particular individual CLL. So there might be factors that might predispose them more likelihood to develop Richters, and some of those mutations going back to, such as a TP53 mutation or a Notch mutation, for example, are more predisposition to go. It doesn't mean that they do, but as a more predisposition. And so they might have that develop sooner rather than somebody else who might be favorable, and you wouldn't expect that to happen, and that might happen much later. So I do think part of biology will probably play a factor in that. And we're hoping some of these time-limited approaches where you're getting undetectable MRD might mitigate for that, but I think only time will tell.
And I would add complex karyotype to that too.
Absolutely correct. Which
And
is
I look at that, if your CLL tends to mutate, then you're at higher risk for everything, including Richter's. And that's when you want to look at maybe a therapy that really drives it really low. So that's why, even though these new drugs will work, whether you're 17p deleted or not 17p deleted, that's one of the reasons you want to know when you're making these decisions. Let's take a step back and explain some terms. And I know you went over these terms, but could you explain to us again the difference between covalent and non-covalent and why that's important?
And this really, sorry, hopefully we didn't make it too complicated. This is really where the covalent BTK inhibitors are where they bind to BTK. And so the binding pocket, and so they're irreversible. So they lock in at C481. The non-covalent BTK inhibitors are irreversible. And so they don't have to be bound to that necessarily to do its job to block BTK. So it's, so that just separates, it has to do with their binding. And that's a difference. And that's why we separate the group, the covalent BTK inhibitors, and that's the three that are FDA approved, Bruin, Acala, and Xanu. And the non-covalent BTK inhibitors, we have Pirtobrutinib and there are Venetoclax and hopefully others in development as well. So it just has to do with how they bind to BTK.
And let's look at some of these outcome measures because they can be confusing. And if we could go over progression-free survival, duration of response, treatment-free survival, and overall survival. Could you, and because you see all of these in papers and, you know, the numbers are kind of all over the place. Can you remind us what those mean? And if you're a patient, what should you be looking for? I know what my answer is in my head, but I want to hear what your answer is. Yeah.
Well, let's see if we can define all the terms first. So, and if I forget, you have to say
overall. Let's start with overall survival.
It's really time from, you know, treatment to, I mean, so when we follow on a trial, to be the time that you're starting the treatment to your survival, regardless, whether that be from CLL or another reason, right? So overall survival is somebody they can succumb to something else, but it takes into everybody into consideration for overall survival. Progression-free survival is the time from starting therapy to the time point of progression or death, whichever comes first. So then they'll mark if you're starting to progress, then they know if your white count's starting to go up again, that's the time period that they'll nick off on the on the trial that, okay, that person's starting to lose their response. So they'll count that in as your progression-free survival. And the reason why, you know, they use you'll see a lot of PFS or progression-free survival in the clinical trials is because we know that for CLL patients, as Brian just alluded to before, because people, you know, you guys, thankfully, people do so well and can live years with CLL, that getting to an overall survival endpoint sometimes with some of these randomized clinical trials, meaning looking at one regimen versus another regimen, could take 10 to 20 years or a long time. And so then to get an early readout on a new therapy to see if it's better, we've sort of substituted as a surrogate, maybe poor, but I think pretty good surrogate marker of progression-free survival to sort of see, well, if somebody, if they're progression-free survival, the time they're starting to lose their response to a particular therapy sooner, that compared to another arm, that then, you know, we have an early readout about a particular regimen. And so PFS has become sort of almost in a way a little bit substituted for overall survival just because of the fact that CLL folks do so well for a long period of time. And that's where that's come from.
And as a patient advocate, I push for that in trials because we want to see these trials get to market. And right. Can be a marker. And there are some studies looking and saying, yes, there is a good correlation. That's not always the correlation with other cancers and solid tumors and other things like that, but it is in CLL. But I think it's also incumbent on the researchers to say, that's great. We've got this drug, maybe an accelerated approval, a provisional approval sort of, but let's make sure it really does an overall, because sometimes we get surprised and there isn't an overall survival advantage down the line. So but I don't want to, if we have to wait for an overall, we'll never have any new drugs in CLL.
Agreed. And that's why it's still important. Like when we talked about some of these trials with longer follow-up that I presented, for example, with some of these abstracts, you know, we're still going to be following these studies because hopefully we'll see that eventually there is an overall survival, that the curve split and that it it went in line with what we thought about earlier when the progression-free survival readout was good, but sometimes curves also merge. And so again, really important to have longer follow-up, but we need something on a shorter interim basis so that we can get drugs and combinations and things moving along. Otherwise, if we had to wait to read out for overall survival, it wouldn't happen.
Remind us what treatment-free survival is.
So the time period that also that you're not needing to, after you've achieved a good response to therapy, that you're not on therapy and you're still alive. And we don't use that as, I mean, we do use it, but you'll see that we don't use it as much. PFS tends to be more of a heavy weighted thing than, let's say, treatment-free survival, although that's important. And then we could talk to treatment time to next treatment. I mean, that's another indicator as well. So there's lots of these jargon and terms in the clinical trials that are important, and maybe, depending upon a time limited therapy, some might be more important than others, versus if you're taking a continuous therapy, that maybe some of these terms are not relevant. So it depends on also the type of treatment you're getting when you're looking at some of these indicators, because it might be then, well, what's your time to your next treatment if you've been on a continuous therapy versus you've gotten a treatment-free period because you've been on a time-limited approach, and then when's your time to your next treatment? So it is relevant depending upon the types of therapies you get. So I think PFS would probably be the overall, at least for you all to keep in mind.
And I would make the point, like I had CAR T therapy, as a lot of people know, and my CLL started to show up again by next generation sequencing, clonoSEQ, 1 in a million cells. So my progression-free survival, that was the mark, right? I'd progressed from 0, undetectable, to 1 in a million. Did I need treatment? No, I went another 2.5, 3 years before I needed treatment. Right. So from the patient's perspective, that's all nice. I have 1 in a million cells. There's nothing to do about that, So I think that that's important. Here's one that you do see a lot, and I really want you to spend a moment on this one: duration of response. Does that apply only to if we do a study and 50% of the people respond? Is the duration of response for the 100% of the people who in the trial had the intention that we treated, or is it only for that 50% that we did treat?
Yeah, so this is really important because let's talk about, let me see if I can put this differently. So, a lot of, when we look at responses, you'll see fancy terms such as complete response. So no evidence of the CLL, complete response with minimal residual disease or not. Partial response, still evidence of disease, but responding to therapy. So, sometimes studies look very good, meaning somebody might get a complete response, but perhaps they'll relapse quick. I mean, duration of response means how long does that response last? And, historically, when we've treated CLL, the notion that we've shown in many clinical trials is that if you can get to a very good remission, or either a complete response with undetectable disease, or a complete response even with some disease, that the response duration, how long that response will last and benefit the patient, would be longer in duration. So then, i.e., if you're on a time-limited approach, whether back in the day chemoimmunotherapy, such as FCR or bendamustine or rituximab, or a time-limited Venetoclax with obinutuzumab, that if you get a complete response, that the likelihood is that that response will be more durable. It will last longer, and you'll have a longer duration being off treatment, as Brian had noted, before needing your next line of therapy. And so that treatment-free interval or duration of response is important, because there are some regimens where maybe somebody looks like they get a very good response, but then it's not as durable. And so you need to, that's an important thing to keep in mind as well. So sometimes it's not all about the, you have to, depending upon the type of treatment it is, those type of details are important. And so, I think for patients, you want to look about durability, because you want to know, how long am I going to be off of a particular drug? If it buys me time off of drug, that might be more meaningful to me. Right, to be off drug for a period of time, because it's a very durable response. And so, I think for what Brian was talking about as an example for CAR T, we know that the patients who got a complete response, even though they're not the majority of patients, that in the patients who got a CR, that was durable. If you did not get a CR, it was not durable. And that's important for CAR T. So now we know that about CAR T. So it also depends on the type of therapy.
And I would add to that an emphasis, just a lot of trials like to boast about their overall response rate. And while that's important, it's probably the least important thing. You don't want a trial where only 10% of people respond. But if 90% of the people respond, but the responses last 2 months, big deal, you know? So it's really important to look at these other factors and not be wooed by a high overall response rate. And that's the first thing you get. Like, I mean, you give the drug and, you know, do the nodes shrink? Does the count go down? You know, I mean, you know that right away. Let's talk about one of the exciting new drugs, Pirtobrutinib. Do you ever see this moving to a frontline setting? Do you have a sense of that? Somebody's asking about this already. And do we have any long-term data on it? What's the longest data we have on Pirtobrutinib at this?
You have smart patients on this webinar. Obviously the Bruin study, we now have over 30 months of data on that from now. That was obviously relapse refractory, but as noted, there are many phase 3 studies with Pirtobrutinib in combinations, looking at, for example, Pirtobrutinib, Venetoclax, and an antibody versus Venetoclax and Rituximab. There are relapse studies as well as upfront studies. So yes, there are clinical trials with Pirtobrutinib in previously untreated CLL patients to see whether or not they'll, would that be supplant the other or be the first instead of the covalent BTK inhibitors, would that supplant the covalent BTK inhibitors in frontline therapy? These are studies that are currently ongoing now. The data is too immature. Can I see that happening in the future? Yes, although I think that a lot of people will want more long-term follow-up, obviously, compared to, we have, 10 years worth of data on covalent BTK inhibitors. And so, it's, very good data. And so the question is, it's not that I don't doubt that Pirtobrutinib or the non-covalent BTK inhibitors can do well in the frontline setting. I think we all have to think about how we can sequence these agents for you guys over time. What's the best strategy to sequence between the covalent and non-covalent BTK inhibitors? So too premature to comment about the frontline studies.
We talked about second cancers. Somebody asked a question about diabetes. I know of no relationship between CLL and diabetes. Is there any?
Not that I know of. I don't know.
We know that chemo drugs can cause a brain fog. Do you see a brain fog with any of the new novel therapies? Is that an issue? I know with some of the immunotherapies, people get this ICANS, this neurotoxicity, which is a little different than the brain fog, I think. Can you talk to us a little bit about that?
Yeah, I mean, you're right, Brian. It's not something, we heard it more traditionally with chemo immunotherapy. I mean, when we talk about the oral agents, it's really hard to know. It's obviously not something I hear commonly from my patients who say, I'll never say that. Somebody may say, well, when they've had a break off of a drug, an oral drug, whether it be a BTK inhibitor or Venetoclax, when they go, something I feel differently now that I'm off drug. I feel better, for example. But have I heard that across the board? No. So, I mean, I'm sure there's some things that even the targeted therapies might make people feel a little, vague or different, but it's not a common complaint I hear similar to what we think of when we talk about chemo fog. Or I can't, like what you were talking about with the acute neurotoxicities of some of the immunologic therapies, which are more in the short term. But it's not something I hear commonly with the BTK inhibitors or Venetoclax. But I mean, can I say absolutely that they couldn't feel, a little off? Probably everybody can go through a range of symptoms, but that would definitely be on the lower incidence for the targeted therapies.
There's always a question about diet, and I'll start with that. There was evidence that a Mediterranean diet is the best diet for CLL. It's also the best diet for heart disease, for arthritis, for everything. So a Mediterranean diet. There is also clear evidence that if you exercise regularly, you do better with any kind of cancer, including CLL. And there is evidence that if you get a good night's sleep, I say every day you take your meds. So the M stands for meditation, the E is exercise, the D is diet, and the S is sleep. Every day take your meds and you're going to do fine. There is no particular diet that cures CLL. And believe me, if there was, I probably would have found it because I've tried everything myself, vegan, raw, low glycemic. There's also this, and talk to us about this. You talked about the PET scans and they pick up the sugar and the sugar lights up. And so if I eat low sugar, I'm going to starve my cancer. You must have heard this a million times, right? Talk to us about that, because we get that question all the time.
Yeah, I mean, obviously it's not like we've run a clinical trial to really sort this out and do this. I mean, obviously we know that, there are certain things that impact, I think like when you talked about the Mediterranean or taking good care and moderation and everything that you're doing impacts your immune system. There's no doubt. I think if people were, have terrible diets and are, uncontrolled diabetes, do I think that's going to impact their CLL and their cancer? You betcha, I do. So I do think that is true, but do I think that people should completely starve themselves? I mean, I think moderation is key. And, with everything that you do in life, including your diet and exercise too. I don't think there's anything wrong. I think what affects cardiovascularly, if it's helping those systems, like you were talking about the Mediterranean diet, the likelihood it will help your cancer. That's probably, I agree with that. It's just that we haven't done certain studies to see this enough in CLL patients, probably for many reasons, including lack of funding and time. But do I think that you need to, if you can take care of your whole body, will that impact and help you in your CLL journey? Yes. So you do need to control your other medical problems. And I like your meds. I hadn't heard that before. I don't know why you didn't. I didn't hear that, Brian, but I like that acronym of, sleep and exercise and so on, and meditation. I think all those things also help your immune system. We know that there are individual studies about all these things in cancer, that those will likely also help your CLL as well and your immune system. So I do think that's true.
So I stole that med line from an Australian surfer with prostate cancer, who's done very well with that. Let me ask you, a lot of people are asking about getting back into the world and immunity. I think the short answer is, at this point, other than some of the things we talked about, this sort of anti-inflammatory approach to life, and there's a role for immunoglobulins in some patients, but there's nothing that we know that really boosts immunity at this point in CLL. That's another, what we see at CLL Society is a great unmet need. Is there any research that has you excited, or anything that you're seeing that maybe this is the breakthrough coming, or is it still very early in this?
It's still very early, although I am excited that there are individuals wanting to look at this more than just infection rates and immunoglobulin levels in CLL, because as we know that notoriously has been not necessarily perfect. The fact that we use gamma globulin hasn't worked for all individuals, and also that immunoglobulin levels might be a notoriously poor surrogate marker for people's immune system, because we have some patients who have low levels and never get sick, and vice versa. So I think that we do need to do better, but there are definitely individuals who are trying to tap in and look more with regards to immunity in CLL patients beyond just infection rates. So stay tuned, but it's very premature. I know, since you mentioned, Brian, about COVID and getting out into society, and it's a very hot topic for CLL patients. That thankfully, patients are doing better. It doesn't mean that you're not getting COVID, but compared to obviously what COVID was in 2020 is not quite the same. We still take all these infections seriously in our CLL patient population. So I'm glad patients are getting back out and doing more things. But if you get sick, please let your physician team know, whether it be your CLL doc or whoever your internist or primary care doc that you deal with, to talk about infections. Because if you have a complication post-COVID, we need help, right? So some people do get bacterial infections and things after a viral infection. And so we don't want you guys getting too sick. So just keep us in mind.
Here's one. I'll take this one, and you can chip in on this. Someone said their count dropped after getting a COVID vaccine, a significant drop in their ALC, or their white count. And the answer that I'd have is, before we had any treatments, we knew that stimulating the immune system could do that. And we still treat bladder cancers by giving people a little bit of a tuberculosis virus that's higher made inert, to stimulate the immune system. And so stimulating the immune system can sometimes knock back the cancer. There's been cases of people getting strep infections where their CLL has been knocked back. What doesn't kill you makes you stronger kind of thing. So it's not a recommended approach, to get sick, but seeing a count drop. But I've also seen the other where people's had a COVID vaccine and their nodes have swollen up and they've gotten more inflamed and their counts have gone up. And they don't always go all the way back to normal. They usually fall a little bit, but they don't always go back. So that's not a predictable approach to doing this. A couple quick things. Tumor lysis syndrome, it's a risk with Venetoclax. It's a risk with a couple other things. Any long-term problems with it, if you get through the potassium and uric acid, you're fine, right? It's the same as with cytokine release syndrome, right? With the, if you get through it, and generally if you get through the ICANS, the neurotoxicities. Somebody asked about bispecific T-cell engagers. Seeing as I'm going through that and doing extraordinarily well on my epcoritamab trial, I'm happy to say an undetectable measurable residual disease and a complete response. And I'm one of those difficult to treat patients. The way that works is antibodies are Y-shaped. And so one part, like if you look at rituximab or obinutuzumab Gazyva, both have the same markers that attach to the CLL cell and say, come and get me, I'm a bad cell here. But what the bispecifics do, bi is 2, so one attaches to the CLL cell and the other attaches to the T cell. So instead of waiting for a T cell to float by, it just pulls it over and it attacks. So you get a much higher kill rate. Because of that, you can also get the same kinds of things you get with CAR T therapy, the cytokine release syndrome and the neurotoxicities. But it's very, very, very early in CLL. But there is some encouraging data for difficult to treat patients. And I think people are looking at it in different ways. Often looking at a mop-up therapy. If we don't get to MRD, could we wipe out a little residual disease with this? So I think that's pretty interesting. PI3 kinase inhibitors. We don't hear much about those anymore. There was some stuff about intermittent dosing and stuff. Is there any news on that you're hearing as a researcher?
Yeah, no, I mean, unfortunately, because of all these, all the therapies that are coming about, PI3 kinases are still available in the relapse setting, but obviously it becomes a little bit more challenging when you're getting all these promising therapies as well due to some of the side effect issues. So although intermittent dosing strategies might actually, mitigate for some of the toxicities that we see with the PI3 kinase inhibitors, I'm not sure how, where that will fit in the spectrum of all the therapies, given what's going on right now currently.
RSV vaccine, are you recommending that for your CLL patients under 60?
Yes, although some people, I'm hearing that obviously some patients are getting pushback at their pharmacies and I might need a prescription. So just keep that in mind.
And I'm just to mention, somebody asked about Richter's and they've got it and they're in a deep remission. I would suggest to that person that they discuss with their doctor a second step, which is often a transplant, if that's appropriate. That may or may not be appropriate, but transplants have a curative intent with Richter's, and most other therapies aren't curative. It's a big step to go through, but it's something definitely that should be on the radar screen for anybody with Richter's. We're down to our last couple minutes here, so I'm going to give that to you, Dr. Lamanna. Any final thoughts about this? ASH, I think, was an evolutionary, not a revolutionary. We didn't say, oh my God, we used to treat CLL like this. Now everybody's going to go like this. But there was a lot of new data and new interesting things. I wish there was some more new targets. The degraders excited me. There was really almost nothing on the bispecifics in CLL, and those seem to be the two new hot drugs.
Yeah, I think it's early. I think the degraders and the bispecifics just need more time, and I think you'll see some novel combinations with these agents. But you're right. I think that a lot of this was more about prolonged follow-up of some of the trials, a little bit about MRD and how to maybe utilize MRD testing. And then also looking at longer follow-up from some of these studies, which is important, I think, to give people a sense of where they are, not necessarily something new. And then, of course, I think another big thing is that we're all trying to figure out how best, now that we have many different treatment options, which is great, how best to sequence different treatment options, and how do we, how do we look at sequencing in different patients, and look at different mechanisms of resistance, and then how, how can we utilize that information for next lines of therapy for somebody who progresses again with CLL. So like you said, I think not necessarily revolutionary, but a lot of steps with longer follow-up and moving forward. And we have a lot to be hopeful for. And there's lots of very, very interesting clinical trials that are coming about. And hopefully we'll get at more answers with more time and more follow-up. So
I think the sequencing, the combinations, the role of MRD, all of that's pretty exciting. And there are some pretty interesting new classes of drugs that are on their way. So first, I want to thank Dr. Lamanna for her incredible presentation and answering these questions. And I think it was great. I want to thank our generous donors and the grant support from AstraZeneca. And thank you all for joining us today. There's going to be an event survey at the end, and please provide your feedback. It really helps us. We read every single comment. We look at this. It's very important to us. So please take a look at that. All of these are recorded, and Brad, who runs our IT, is pretty slick at getting these up and online for you to watch it, to rewatch it, and recommend it to your friends. We have a really interesting webinar. CLL Society is sponsoring research. We talked about there not being research going on in terms of diet, exercise. Well, we're going to be sponsoring research in that, and we have some really strong applications for that. And we're going to talk about integrative oncology and what its role is in managing CLL, and that's coming up on March 19th. So stay tuned for that. That's going to be very interesting. Again, if your question wasn't answered, please send it in to us. Remember, CLL Society is invested in your long life. Please invest in the long life of CLL Society by supporting our work. We are a 501c3. And again, as people have heard me say, smart patients get smart care. Thanks for attending. Thanks for making yourself smart. Stay strong. We are all in this together. Thanks to everyone.